Okay. Yes. Am I audible to all? Okay. So am I visible to all now? So today we are going to discuss medicine topic, INICET. Okay. So let us start with our MCQs. Okay. So our first MCQ, syndrome X is. What is syndrome X? This syndrome X is because of the obesity, mainly obesity. Because of obesity, resistance to insulin increases. When resistance to insulin increases, demand of insulin increases. When demand of insulin increases, it will increase workload on beta cells. Now, number of beta cells are normal, but demand of insulin is increased. So these beta cells, they will synthesize more amount of insulin. So concentration of insulin in our body, in the body of patient, it will increase. Okay, but resistance to insulin is very high. So even if concentration of insulin is increased, it is not sufficient and it is not able to decrease the sugar. So patient develops diabetes. So patient having metabolic syndrome, it is having increased risk of diabetes. It is a correct sentence. Second sentence, due to X chromosome mutation, no, it is not associated with X chromosome mutation. It is not associated with Turner syndrome. It is not a pre-malignant condition. A very simple MCQ. Syndrome X, it is these patients are having increased risk of diabetes because of obesity. There is increased risk of insulin leading to diabetes. Second, which of the following is false about COVID-19? Which of the following is false about COVID-19? It can be transmitted from humans to animal. Yes, it is possible. Suppose infection is present in human and this virus, it is spread through the cough. It is present in the nasal droplets. So if human is coughing and if these nasal droplets, they enters in any animal, then that animal also can get the infection. But this animal, he will get disease or not, it cannot be said. But virus can travel from human to animal, can be detected through salivary diagnostic test. Now, this virus is mainly present in nose and in mouth, larynx, trachea. It is mainly a respiratory tract infection. First, it infects upper respiratory tract, then it goes to lower respiratory tract. And now, when person or patient is having salivation, this virus, it will also enter in saliva. So when we are doing the RT-PCR test during COVID, we are collecting the secretions of the larynx, we are collecting that swab from the posterior pharynx. So it is nothing but the saliva or secretions. So you can diagnose this patient on the basis of saliva or on the basis of secretions in mouth. It is encapsulated virus. Yes, it is a encapsulated virus. Then it is secreted in sweat from sweat glands. No, there is no evidence that this virus is secreted in sweat glands or in sweat. Okay, so this virus is spread only through the nose or through mouth during coughing, when droplets from saliva or nose, they are going out and they are inhaled by the other person or animal. Now next one, role of diphenhydramine in dental surgery. This diphenhydramine, it is an antihistaminic. It is antihistaminic, so it decreases histamine. It will prevent the release of histamine, and it has no role in epilepsy. It has no role in epilepsy. It has no role in arrhythmias and xerostomia. This diphenhydramine, it is also used commonly in medicine if patient is having any allergic condition like urticaria. Okay, it is used for any allergy. Even if patient is having allergic cough, you can give the cough syrup having diphenhydramine. And this diphenhydramine, it also causes sedation. Okay, so patient can become drowsy or sleepy, so you have to tell the patient that preferably you have to take this medicine at the night time. Okay, these are the uses in medicine. In dental, we give it for allergic purpose and or to prevent any allergy or to decrease the inflammation or to prevent the formation of inflammation. Okay, other uses in medicine, you have to know it is used for dystonia, insomnia, pruritus, urticaria, vertigo, and motion sickness. These are the other uses of diphenhydramine. Then, which of the following will not lead to ketoacidosis? Starvation, it can lead to ketoacidosis. Starvation, what is happening? Patient is not getting food, so patient simply not getting the glucose. And when body is not having glucose, then body has to get wants energy to get to for energy. Now body will start destruction or breakdown of proteins, breakdown of fats. And when fats are broken down, these fats can be converted to formation of ketones. So mainly fats are responsible. Destruction of fats, it is responsible for formation of ketones. So starvation ketosis possible. Low fat, high carbohydrate diet. No, low fat is not possible because it needs fat for formation of ketone. Diabetes mellitus, type 1 diabetes, diabetic ketoacidosis, it is very common in type 1 diabetes. Then high fat, low carbohydrate diet, yes, high fats can cause ketosis. So answer is B. Now actually what happens? What is meaning of ketoacidosis? Suppose I will take the example of patient of diabetes. These patients are not having insulin. In these patients, suppose this is fat or adipose tissues. This is fat or adipose tissue, and triglycerides are present. Triglycerides are stored in this adipose tissues. When triglycerides are converted to fatty acid, when triglycerides are converted to fatty acids, this process is called as lipolysis, and this process, it is inhibited by insulin. This process is inhibited by insulin. So normally insulin inhibits lipolysis. Now what is happening in type 1 diabetes? Insulin is not there. Insulin is absent. So when insulin is absent, there is no one to inhibit lipolysis. So this lipolysis will increase and triglycerides will be converted to fatty acids. Now these fatty acids, they will enter in blood. They will enter in blood. So these fatty acids from blood, now they will go towards liver. From blood, they will go towards liver. This is liver. Now lot of fatty acids, they are entering inside the liver. Initially, liver will convert these fatty acids into glucose. This process of formation of glucose from fatty acid, it is called as gluconeogenesis. Gluconeogenesis means formation of glucose from non-carbohydrate substances. And now this glucose, it will enter in blood. Okay, so it is also responsible for increasing glucose. But now what happens? Lot of fatty acids are entering in liver. Liver is not able to convert all fatty acids into glucose because liver is having limited enzymes. So these fatty acids, they are transported to mitochondria. They are transported to mitochondria. And in mitochondria, these fatty acids, they are converted to ketones. In mitochondria, fatty acids are converted to ketones. And now these ketones are formed, and now these ketones, they will enter in blood. So it is the process of formation of ketones. Process is same in all the cases, just cause is different. In this patient, insulin is not there. That's why triglycerides are used. In starvation, glucose is absent. So glucose is absent. So what will happen? Body will use triglyceride for formation of glucose, and in that process, ketones will be synthesized. In low carbohydrate diet, again glucose will be insufficient, so body is not getting the glucose and body is getting the fats. So now fats will be converted to ketones. Okay, so in patients having low fat diet and high carbohydrate diet, if patient is taking high carbohydrate diet, then body will utilize the carbohydrates, the glucose, as a form of energy. Okay. Now, what is the purpose of Glasgow Coma Scale? Now, this Glasgow Coma Scale, a very famous scale, it determines the level of consciousness of patient. Okay, so it is used in mainly stroke patients, unconscious patients, to know what is the level of consciousness of our patient. So it's a very simple MCQ. It is to determine the level of consciousness. Okay, it to segregate patients in triad setting, no, it is not used for that. Determine outcome of traumatic head injuries, no, it can tell you the what is the condition of your patient, but it cannot tell you what is the outcome, what will be the prognosis, good prognosis, bad prognosis. Okay, then to allocate patients in emergency services, no, it is not used. It is the only use that what is the condition of our patient. What is Glasgow Coma Scale? I will show you. In Glasgow Coma Scale, we are having different variables. We are having eye opening, motor activity, and verbal. Now, if patient is opening eyes spontaneously without any command, patient himself or herself opening eyes, then you will give 4 points. If spontaneously patient is not opening eyes, then you will give a verbal command. You will call him by his name. After calling him by his name, if he is responding, he is opening eyes, then it is a 3.3. If patient is not responding to verbal command, then you will give a painful stimulus. Okay, and after painful stimulus, patient is opening his eyes, then it is then 0.2. And after giving painful stimulus, patient is not responding, then only 1 point. So according to your patient clinical feature, you will give the points. Okay, eyes we are having 4 points. Then motor activity. In motor activity, we are having 6 points. 6 verbal come. If patient is talking normally, patient is following your verbal command. If you are asking the patient to show the tongue, patient is showing his tongue, it means patient is understanding, patient is performing the activity, then it means 6 points. Then if patient is not able to follow the command, but patient can localizes the pain, if you give pain stimulus to your patient at any site, and if you ask the patient where is the pain, then patient can localize, patient can show by his hand, then it is 5 points. Fourth, withdraws from the pain. After patient is not conscious, and if you are giving pain stimulus, then that hand or limb, it will try to go away from the stimulus, it is withdraws from the pain. Then decorticate posturing. Decorticate posturing means flexion in the upper limb, extension in the lower limb. It is called as decorticate posture. Decerebrate posture means all 4 limbs are in extension. Upper limb are in extension, lower limb they are also in extension. And point 1, only 1 point if patient is not responding to any stimulus. Then verbal, if patient is not intubated and means patient can speak, then a patient is oriented and patient is able to talk, then 5 points. Patient is disoriented, patient doesn't know what is the time, place, person, but patient can talk at least, so you will give 4 points. Then inappropriate words, here patient can talk but patient is not using the proper words. Incomprehensible sound, patient can make a sound but patient is not able to pronounce a proper word, only having incomprehensible sound. The sound, then no response. Patient is not talking, not making sounds. Okay, so according to the condition, you will do the points. And if patient is intubated, the tube is in the mouth, in the larynx. So obviously, this patient is not able to talk. But if patient is opening eyes and is trying to talk, then you can say seems able to talk. Then if patient is not talking, patient is just opening eyes, not able to patient, if you think that patient is not responding, if you are giving pain stimulus, patient is just opening the eyes but not trying to talk, not moving his upper limb, lower limb, then it is questionable that patient will talk or not. And 1 point, patient is not responding. So you will add all these three. You will add E plus M plus V. Suppose patient is very serious, not opening eyes, no response, no movement in the upper limb, lower limb, and patient is intubated and not responding. So minimum score is 3. Minimum score is 3. Next possible MCQ in your exam, that this Glasgow Coma scale minimum score should be. Please remember, it is not 0. Okay. Then all of the following can be measured by spirometer except, now the air which can come out, it can be measured by a machine. A simple logic. Spirometer, it is an instrument which can measure the volume of air. Okay, and now the air which can come out through mouth, it will enter in the machine and machine can measure that volume of air. Now vital capacity, yes, it can be measured. Okay, because vital capacity, it is the capacity of the lung during exercise, or it is maximum forceful inspiration and then maximum forceful expiration. When patient is uh, breathing, suppose patient is running, after running, uh, what will happen, patient will take a deep breath, a deep inspiration. Okay, after maximum possible inspiration, the amount of air which is present in the lung, now patient will start expiration, now air will go out. Now when that air is coming out, the amount of air which is expired after forceful inspiration, it is called as vital capacity. So you can measure this air. Tidal volume means during quiet respiration. Quiet respiration means normal respiration at rest. I am sitting at rest. I am taking a air in, it is a tidal volume. The air going out, it is a tidal volume. Okay. Then expiratory reserve volume. What is expiratory reserve volume? Suppose I am sitting at rest, I take a tidal volume at rest. After this, I will inhale, tidal volume gone. After removing tidal volume, I will try to remove more amount of air, forceful expiration. So amount of air which can come out after removal of tidal volume, it is expiratory reserve. So it can also come out. So you can measure functional residual capacity. What is functional residual capacity? During normal quiet respiration, only tidal volume goes in and out. Expiratory reserve volume and residual volume remains in the lungs. Both these together called as functional residual capacity. Okay, what is meaning of reserve volume? Volume of air that remain in the lung after maximum forceful expiration. Now, suppose if you ask the patient to expire, suppose patient expires, tidal volume. That is, at the rest, air is going out. After removal of this, patient will forcefully expire. Now patient is applying force to remove the air. It is expiratory reserve volume. Okay. Now after removal of expiratory reserve volume, some amount of air is always present in alveoli, which cannot be removed from our lungs. If this air come out, then there will be collapse of all the alveoli. So some amount of air is always kept in alveoli, okay, to prevent the collapse of the alveoli. It is called as reserve volume, or it is called as residual volume. And this volume, it is not coming out, so we cannot measure this volume, but it is present in the lung. Okay, so we cannot measure reserve volume. And what is functional residual capacity? Suppose I have taken the normal inspiration. After normal inspiration, I will expire. Some amount of air will go out. It is tidal volume. After removal of tidal volume, my lungs are having expiratory reserve volume and residual volume or reserve volume. Okay. So this volume of air is present in lung during quiet inspiration and expiration. Okay, it is having a residual volume which cannot be measured, and this functional residual capacity, it is expiratory reserve volume plus residual volume, it cannot be measured. Muscle primarily responsible for normal quiet respiration. Diaphragm is the main muscle which is responsible for quiet or respiration at rest. Other muscles, sternocleidomastoid, scalene, internal intercostal. If we are uh, if we are taking breath forcefully by applying pressure, if we are doing like this, then we are using sternocleidomastoid, scalene muscles, internal intercostals. Okay, but diaphragm, it is the main muscle during quiet. It is the respiration at rest without applying any force. Now, platelet function is assessed by clot retraction time. It is mainly assessed by clot retraction time. Now, what is clot retraction? Clot retraction is a process driven by outside in signaling by platelet integrin in alpha 2 beta 3 that results in the contraction of the fibrin mesh. The contraction of fibrin clot results in the blood clot becoming smaller and excess of fluid extruded. Okay, so it is the platelet function. So platelet retraction time is done for platelet function. Then sublingual nitroglycerin is effective because this sublingual nitroglycerin this nitroglycerin this drug is non-ionic and high lipid soluble. It is non-ionic and high lipid soluble. Our cell wall, it is made up of lipid, so it can easily enter in cell and it can be rapidly absorbed. So we can use nitroglycerin sublingually. In a patient of ischemic heart disease, angina, heart attack, we use this nitroglycerin. Acceptable T cell count in HIV positive patient for performing dental surgery. When patient is having HIV, then CD4 cell count is very important. T cell count is called CD4 cell count. When this CD4 cell count goes below 200, then patient is having risk of pneumocystitis, Girovacchi pneumonia, chronic herpes simplex ulcers, esophageal candidiasis, Isospora belli, okay, HIV wasting syndrome, HIV associated dementia, peripheral neuropathy, endemic mycosis. And if CD4 cells, if they are more than 200, then patient is having risk of TB, bacterial pneumonia, herpes zoster, oropharyngeal candidiasis, non-typhoid salmonellosis, Kaposi sarcoma. If patient is having HIV and if you want to perform dental surgery, then according to guidelines, at least patient should have 200 cells per microliter. Okay. If it is less than 200, then it's very likely that patient get the infection of pneumocystitis gonorrhea, which is very difficult to treat in these patients. Next, which is not an essential part of history taking form of COVID-19 in dental setting. History of sore throat, fever, cough. Yes, this is very important. If patient is having history of sore throat, cough, fever, then this patient is having infection and patient may spread the infection. Residing in containment zone plus minus patient residing in containment zone doesn't mean patient is infected. Okay, there is a possibility that patient might be infected. Okay, but you cannot say 100%. History of diabetes. History of diabetes is very important in all the patients. Even if patient is not having COVID-19, it is important. In COVID-19, it is having a very important. It is having importance because this COVID-19 infection, it was causing a serious disease in a diabetic patient. So if patient is having diabetes and by mistake patient is also a case of COVID-19, then there is possibility that patient may get pneumonia. Contact with COVID-19 patient in last 14 days. Yes, this history is very important. Suppose patient is having history of contact with COVID-19 positive patient, or at home his brother, his sister is having COVID-19, then it is a highly infectious disease. So there is a very high chance that this patient may have infection of COVID-19. So in all these four, actually all these four were important, but in all these four, less important is residing in containment zone. Okay. And then next one. Which of the following represents the most common source of pulmonary embolism? The most common source of pulmonary embolism, they are the deep veins of legs. So any thrombus present in the deep veins of legs can give the embolus. This embolus from deep veins of legs, it will enter in IVC. From IVC, it will enter in heart, right atrium, right ventricle. From right ventricle, it will enter in pulmonary trunk. Then it can enter in lungs. It can block the blood vessel of lung. Okay, so any thrombus, any embolus in a vein, it is a risk for pulmonary embolism. Most common is thrombophlebitis of the deep veins of the leg. Now, esophageal varices, no, it is not the common site of thrombus formation. Esophageal varices, they are just dilated esophageal veins. End arteritis, it is the inflammation of the end arteries, like arteries of retina. Okay, then lymphangitis, no, lymphatic system is having inflammation, but the common source is thrombophlebitis. Next, a child gets epileptic seizure in dental chair. Which of the following is the first drug to be administered in this child once active seizure subsides? Now patient is having epileptic seizure, but what is the type of seizure, it is not mentioned. Now we have to choose the drug according to the type of seizure. Now we have to select the best drug in out of these four. So injection eptoin, generally it is commonly available and it is used commonly. Eptoin, tablet eptoin. Now if patient is having seizure, Then tablet will enter in mouth, then esophagus, then stomach, then it will be digested, it will be absorbed in blood, then it will go to brain. So it will take a lot of time to act. Once seizures are controlled, patient is conscious oriented, you are going to discharge the patient. Then one day before discharge, you can shift the patient to tablets. But during emergency, it is not useful. Midazolam nasal spray in children's, when in children you can use the nasal spray, but if both options are available, patient is in the clinic where IV access is possible. In most of the procedure before dental procedures or normal medical procedures, we keep one intravenous line just for emergency. So intravenous drug, it is more effective than nasal spray. But if your patient is having very high risk and you have discharged the patient, but patient is having very high risk that patient may get the seizure, then with patient we on discharge we give midazolam nasal spray, that on the road or anywhere outside the hospital, if patient is having seizure, then his relative, his friend may give the nasal spray of that midazolam. So it is also very useful drug, but in hospital setting we prefer IV drugs because they are more effective. Injection sodium valproate. Now valproate, it is having a lot of side effects, and first drug which is given in such patient is ectoin. So we always prefer ectoin. And if lorazepam it is given on the option, then lorazepam will be the more effective and it is the first line drug for seizures. Lorazepam, it is mainly for status epilepticus. First line drug for status epilepticus is lorazepam, which is dematicuous or black fungus. During COVID-19, we have seen a lot of patients of black fungus. Okay, that's why this question was asked. Actually, it is a Ochronis type of fungus. It species of Vericonos and species of Ochronis. They are dematicuous fungi. They are generally found in the environment, but having the ability to infect humans, dog, cat, poultry, and fish. When patient is having low immunity, when patients are immunocompromised, then this fungal infection can cause a very, very serious infection. Okay, so if patients are diabetic, then these patients are already immunocompromised, and patient is getting COVID. For COVID, we have to give steroids. Because of steroids, what happens? Immune system is suppressed. So there are increased chances of getting black fungus or any fungal infection. B-type oxygen cylinder is usually kept in dental office. What is the oxygen capacity of this cylinder? Now, the oxygen capacity of this cylinder, you have to remember this no concept, 1200 to 1500 liters of oxygen. Okay, in next exam they may show you the picture of cylinder and they will ask you what is the type of cylinder, what is the capacity of the cylinder. So it is commonly used in our wards, in most of the clinics it is available. So just remember, all of you know this cylinder, it is a B type cylinder for oxygen. Then what is true about COVID-19 serum antibody test? Detects current viral load? No, it is not going to detect a viral load. Antibodies are the produced by our immune system against the virus COVID-19. It is not detecting the virus. Establishes presence or absence of immunity to new infection. Now, it will not tell you that presence or absence of immunity to new infection. It will not going to tell you the infection is new or old or immunity against new infection. It can be immunity to past infection. New infection, past infection, both are possible. Antibodies present, then mainly it is because of the past infection, not because of the new infection. Detects if patient had a past infection with COVID-19. Yes, it is the more correct answer. That patient gets the infection, immune system stimulated, immune system produces antibodies against COVID-19. our immune system is successful in destruction of the virus is destroyed, and these antibodies they will remain in our blood. Okay, so if these antibodies are present, it means our immune system successfully destroyed the infection. It is suggestive of past infection. Okay, then shows immune status of a person who is freshly exposed. No, if person is freshly exposed, then you will detect the RT-PCR, that is the virus from the secretions. You are not going to test the antibodies, because formation of antibodies it will take at least 1 to 3 weeks. So if patient is exposed today, patient gets the infection today, then antibodies will be found after at least 1 week. Maximum it can take 3 to 4 weeks. In pregnancy, ESR increases because of increased level of pregnancy. It is a hypercoagulable state. Okay, in pregnancy, it is also associated with hemodilution. Now, in pregnancy, what happens? The level of fibrinogen increases. Level of fibrinogen proteins it also increases. Gamma globulins also increases. So when all these substances, fibrinogen, gamma globulin, proteins, they are increasing in blood, so what will happen? They will increase erythrocyte sedimentation rate. So it is not having any mechanism. Just we have to remember, in pregnancy, ESR increases because increased level of fibrinogen. Because increased level of fibrinogen. Erythrocyte sedimentation rate. Simply now one theory is proposed. It says erythrocytes are sedimenting down. This time taken by the erythrocyte to go down, it will increase in pregnancy because a lot of things are present in blood. Plasma proteins, fibrinogen, globulins, they are increasing in pregnancy. So the time taken by their RBCs to go down, it will increase. If these things are less, then resistance to RBCs, it will be low and RBCs can go down very fast. Then ESR will decrease. Next, a 65-year-old patient presents with systolic BP of 190. Here systolic BP of 190, diastolic BP of 100, heart rate 74 minute, pulse pressure is 90. Pulse pressure is 90. Decrease in which of the following factors is responsible for wide pulse pressure? Pulse pressure. Now, what is meaning of pulse pressure? Pulse pressure is equal to systolic BP minus diastolic BP. Systolic BP is 190, diastolic BP is 100, so pulse pressure is 90. Now they are asking decrease in which of the following factor is responsible for wide pulse pressure. Means if I want to increase wide pulse pressure, what should be decreased? Answer should be decrease in diastolic BP. If I want to increase the pulse pressure, it means I want to increase the difference between systolic BP or diastolic BP. So either I have to increase systolic BP or I have to decrease diastolic BP. So answer is diastolic BP, and diastolic BP is dependent on the resistance given by the arterial compliance. All of the following are features of fetal alcohol syndrome except. Now when she is pregnant, she is drinking alcohol. This alcohol can directly cross the placenta and it can damage the fetus. If fetus is damaged, it is called as fetal alcohol syndrome. And fetal alcohol syndrome clinical features are short palpable fissure, epicanthal eye folds, poorly formed ear concha, thin vermilion border, okay, and a smooth filter. Wide forehead, it is not the feature of fetal alcohol syndrome. Maxillary hypoplasia, it is also a symptom of fetal alcohol syndrome. Antibiotic prophylaxis before dental procedure is required for unrepaired mitral regurgitation. Now, mitral regurgitation is there. Okay, so patient is not having active injury. Unrepaired atrial septal defect, ASD, it is also not having any injury to heart. That is, mucosa is ruptured, submucosa is damaged like this. Coronary artery bypass graft, CABG is done, but duration is not given. That patient is coming to you after how many months of CABG, how many years of CABG. Repaired mitral stenosis defect 4 months before. Now patient is having surgery for mitral stenosis. So during surgery there must be incision taken, and patient is having some injury in the heart. So there are high chances that patient may develop infection, and duration it is also 4 months. So possibly likely it is not completely healed. So answer will be repaired mitral stenosis because of high chances of getting infection, as patient may have some lesions in heart. Then recommended regimen of amoxicillin for antibiotic prophylaxis prior to dental surgery in a patient with prosthetic cardiac wall. We use 2 gram amoxicillin 1 hour before procedure. Very important for your dental procedures. Please remember this. We use amoxicillin 2 gram 1 hour before procedure. And if patient is having allergy to penicillin, then we are having these options: clarithromycin, cephalexin, cefazolin, clindamycin. Okay. Which of the following is best source for factor 8 concentrate? Whole blood FFP, desmopressin, cryoprecipitate. Cryoprecipitate, it is having coagulation factors: factor 1, that is fibrinogen, factor 8, factor 13, and von Willebrand factor and fibronectin. So cryoprecipitate, it is mainly having the coagulation factors. So it is a rich source of all coagulation factors. It is also a rich source of factor 8. All of the following features can be seen in a patient with erythroblastosis fetalis. Now, what is happening in erythroblastosis fetalis? Mother is Irish negative, father is Irish positive. If baby is Irish positive, second baby, not first, first baby will not be affected. Second baby, it will be affected. Now mother is having antibodies. If second baby is Rh positive, antibodies in baby, it will attack on the RBCs of fetus, so hemolysis will occur. If hemolysis occurs, then unconjugated bilirubin, it will increase in blood. But this unconjugated bilirubin, even if it is increasing in blood, it cannot be excreted in urine because it is not water soluble. Okay, increases bilirubin in blood, yes, it is correct. Hepatosplenomegaly, yes, it can occur because lot of RBCs, they are going, they are entering in liver, spleen. Yellow colored umbilical cord can occur because of increase in bilirubin. Increase unconjugated bilirubin in urine, it is not possible because in urine unconjugated bilirubin cannot enter because it is not water soluble. Clotting time is prolonged in it is prolonged in Christmas. It is prolonged in Christmas disease. Okay, because of coagulation factor deficiency, Christmas disease occurs. It is a coagulation factor 9 deficiency. Thalassemia, it is because of the defect in the globin gene of hemoglobin. So no concept, no reason for increasing clotting time. Thrombocytopenic purpura, platelets are decreased. So patient may have increased bleeding because of decrease in the platelet. There will be defect in the formation of platelet plug, secondary platelet plug. Okay, but clotting time is not going to increase. Clotting time, it is clotting outside the body. So thrombocytopenia, it is the problem when blood is coming out in the body and it is not able to clot the blood inside the body, not outside. Malaria. Now malaria can cause decrease in platelet. What would be the treatment for a dentist who got dull stick injury while extracting tooth in AIDS patient? So now patient is having AIDS and needle used for that patient enters in the skin of dentist. Then what will happen? Now doctor is exposed, so we have to give him the post-exposure prophylaxis as early as possible. It is effective within 72 hours, but we have to give him as early as possible. The current recommendation is we have to use zidovudine plus lamivudine immediately. Please remember the names of these drugs, zidovudine and lamivudine. It should be given as early as possible, maximum 72 hours it is effective. A 50-year-old patient with type 2 diabetes mellitus due to insulin resistance has increased plasma triglycerol. Which of the following is the major cause of diabetic dyslipidemia? HDL, LDL, VLDL, chylomicron. The answer is VLDL. Why? Because these triglycerides, they are mainly present in VLDL, or VLDL mainly consists of triglycerides. I told you what is happening in diabetes. Insulin resistance is increased. Now insulin demand, it will also increase, and concentration of insulin in blood, it will increase. Because of this, lipolysis will be inhibited. When lipolysis is inhibited, then what will happen? Triglycerides will not be converted to fatty acids, so triglycerides will increase, and VLDL is the main form of triglycerides. What should be the first step in the management of an unresponsive patient on dental chair? Now patient is unconscious. Generally we kept aromatic ammonia inhalation, aromatic ammonia with us. There is a swab and we will give them, or we are also having a gas. This ammonia it irritates the nerves which are present in the nose, lungs, and it will trigger the inhalation reflex. Okay, so patient will get a strong stimulus, nerves will be irritated, and patient may become conscious. All of the following are specific complications of alcoholic cirrhosis of liver, except when there is cirrhosis of liver, what is happening? Fibrosis of liver. So because of fibrosis of liver, uh, the sinusoids which are present in liver, they are not able to dilate because of fibrosis. Walls are fibrous, so liver is not able to accept the blood. So portal hypertension will occur. Because of portal hypertension, because of cirrhosis, because of increased pressure in sinusoid, water will leak out. Because of increased pressure in sinusoids, water will leak out from the sinusoid. It will enter in the interstitial space of the liver. From interstitial space of the liver, water molecules will enter in the third space. The nearest third space is peritoneal space. So patient may have ascites. Then patient may develop edema, upper gastrointestinal hemorrhage. Yes, these patients may develop esophageal varices. These varices, they are nothing but dilated veins and they can rupture at any time. If they ruptures, patient may develop UGI, bleed, vague right upper quadrant abdominal pain. No, it is not specific for cirrhosis of liver. Cirrhosis of liver will not cause any pain. This upper quadrant pain, it can be because of liver abscess or liver tumor or any infection of liver, or hepatomegaly because of the fatty liver. But cirrhosis, it is not reason for pain. So answer is D. Condition precipitating heart failure are all except pregnancy, anemia, thyrotoxicosis, myocardial ischemia. Now, if we see all these four options, anemia, hemoglobin level is decrease. So now when hemoglobin level decreases, cells are not getting the normal hemoglobin. Cells are hypoxic. Now what happens? Heart rate will increase. Okay, suppose if hemoglobin is 13, normal hemoglobin, then our heart rate is around 70. Okay, now when this hemoglobin it becomes 6, then cells are not getting the oxygen because hemoglobin is not sufficient. So heart has to pump for 140 times. So function of heart will increase so that this 6 hemoglobin it will rotate in whole body for 140 times. So this anemia can precipitate heart failure. It can cause heart failure. Thyrotoxicosis, T3 T4 increases, and T3 T4 it stimulate beta 1 receptors. Beta 1 receptors they are present on heart. They are stimulated by T3 and T4, so heart rate will increase. So these patients may undergo atrial fibrillation. This patient may come to you with tachycardia, and there are high chances of heart failure. Myocardial ischemia, yes, definitely heart is not getting the blood, so it can fail. Pregnancy, it is not precipitating factor for heart failure. Okay, but if patient is already having a heart disease, like patient is a case of rheumatic heart disease and patient is pregnant, then it can precipitate, but it cannot precipitate a heart failure in normal heart. It can precipitate heart failure in damaged heart. Depth of chest compression in adult CPR. Now, when we are compressing the lungs, we should keep our both hands at the lower sternum, lower one third, and we will apply the pressure. How much? We have to go down up to 2 inches. Okay, generally we go down up to 5 centimeters. So 5 centimeters means 2 inches. All of the following can be seen in a patient with mitral regurgitation except cardiomegaly. Yes, it can occur. Uh, Pulmonary congestion, blood from the left ventricle is going in left atrium, so pressure in the left atrium will increase. So blood from the lungs it is not able to enter in heart, so pressure and congestion in lungs will increase. Wall does not close properly. Yes, it is the reason. This is mitral wall. What is the problem in mitral regurgitation? This wall is opening in opposite direction. So what is happening? This is left atrium, mitral wall, left ventricle. Left ventricle contracts. Normally when left ventricle contracts, mitral wall closes like this. But now what is happening? When left ventricle contracts, this wall is opening in opposite direction. So blood will enter in left atrium. Okay. So sentence is correct. Wall does not close properly. Regurgitation of blood from left atrium to left ventricle. No, opposite should be there. Blood is traveling from left ventricle to left atrium. Which of the following best defines syncope? Now, what is the definition of syncope? Transient loss of consciousness. Transient loss of consciousness because decreased flow to blood. When flow of blood is decreased to blood. So it can occur in hypotension. Hypoglycemia can have a syncope. Hypoperfusion, it is the definition of syncope. Decreased blood supply to brain. Cold abscess can be seen in. Cold abscess, it is characteristic feature of TB. It is characteristic feature of TB. It refers to cold abscess refers to an abscess that lacks the intense inflammation. Okay, intensity is very less. Serological marker for detecting hepatitis B infection during window period. During window period, surface antigen is absent, core antigen it is not detectable. IgM anti-HBC it is the only antibody which is positive. Okay, so IgM anti-HBC. Pulsus paradoxus is not seen in patients with. What is pulsus paradoxus? Fall in systolic BP more than 10 mmHg with inspiration. Okay, when patient is taking the breath, deep breath, then systolic BP normally decreases. If it is decreasing less than 10 mmHg, then it is normal. But if it is decreasing more than 10 mmHg, it is pulsus paradoxus. And the causes are pericardial tamponade, severe obstructive lung disease, massive pulmonary embolism. In these conditions, there will be pulsus paradoxus, but it is not seen in left ventricular systolic dysfunction. Pulsus paradoxus. All of the following drugs are recommended for use in status epilepticus except phenytoin, midazolam, lorazepam. Yes, these drugs are used. Thiopentone. Phenobarbital is recommended, not thiopentone. Okay. So first we use first line drug is lorazepam, then phenytoin and midazolam also comes, then propofol, phenobarbital, then drugs like isoflurane, desflurane and ketamine. What is the percentage of HIV seroconversion rate after an accidental exposure to blood for percutaneous exposure such as needle prick? Now needle prick, it has a risk of 0.3%. Okay, so 0.3 divided by 100. If 100 patients, 100 persons are getting the injury from HIV positive needle, then 0.3 persons will be infected. So 3 persons in 1000 needle pricks. A patient presents with following parameters: pH 7.46, pH is increased normally 7.35 to 7.45. So it is a case of alkalosis. It is a case of alkalosis. So we have to choose between B and D. PCO2 35 to 45 is normal. PCO2 decrease in PCO2 causes alkalosis. So it is a case of respiratory alkalosis. Bicarbonates are compensating for this alkalosis because when bicarb decrease, they will try to cause acidosis. So it is a case of respiratory alkalosis. All of the following are true about tuberculosis in a patient with HIV infection except acid fast bacilli cannot be detected using sputum smear microscopy. Now they are asking about all of the following are true except, so false. This sentence is false. You can detect bacilla in the sputum. The first sentence is false. During early phase of HIV infection, patient has lesion in the upper lobe infiltrates with or without cavities. Yes, upper lobe of lung, it is the favorite site of TB. So patient, it will infect the upper lobe. Cavities are commonly formed, but without cavities infection it is also possible. Tuberculin skin test sensitivity is reduced by diagnosing latent tuberculosis infection. Yes, tuberculin skin test, we are injecting antigen of TB in skin. If antibodies are present, means our immune system is active, then it will attack on that antigen and skin will become hard. Okay, and we will measure the thickness, the thick or the hard skin. But if immune system is very less, if patient is immunocompromised, then this test, it is not having good sensitivity. With progression of immunocompression, miliary TB is seen more often. Yes, it is evidence-based medicine. In immunocompromised patient, miliary TB is more common. Pitting edema can be caused by all except pitting edema. Protein imbalance, when proteins are decreased in blood, water will be shifted to interstitial space. These water molecules are freely movable. Mixed edema. What is mixed edema? Glycosaminoglycans, they are deposited in interstitial space in a patient of hypothyroid, and these glycosaminoglycans, they trap water molecules. So water molecules are not freely movable. If you apply pressure, these water molecules are hold, they are trapped by the glycosaminoglycans, so they are not freely movable. So it is non-pitting edema. Hypothyroid patient, mixed edema, it is non-pitting edema. Renal disease, CHF, water molecules will enter in interstitial space and they are freely movable. What is the most appropriate diagnosis for a female patient presenting with moderate to severe headache attacks lasting for 10 to 12 hours associated with nausea, vomiting, history of severe hypertension, hyperlipidemia? It is a characteristic or classical case of migraine. In migraine, patient has severe attack. Duration of migraine is generally 4 to 72 hours. Okay. Generally, diagnostic criteria of migraine, patient should have any one out of the four. What is patient should have any one out of movement, increases headache, unilateral headache, severe headache, throbbing headache, plus 2 out of nausea, vomiting, photophobia, phonophobia. So patient is having nausea, vomiting plus headache of 10 to 12 hours, it is a case of migraine. Spontaneous clinical hemorrhage is observed when platelet counts fall below normal count 1.5 lakh, above 1.5. When it decreases below 20,000, then patient may develop hemorrhage. Okay, this is completion of our INICET recall.